I'm Ramaswamy Govindan, a professor of medicine at the Washington University School of Medicine in St. Louis. So another challenge we have, in my opinion, it's a good challenge to have, is treating oligometastatic disease. How do you treat oligometastatic disease? This depends on where the metastatic disease is. If there is a single site of brain metastasis, for example, that is in an area that can be resectable um, without any consequence, and obviously resection is the best thing to do. And then the question really depends on whether the mediastinal nodes are involved or not, and at presentation. And of course, there's also a complicating factor at presentation versus subsequently what I call the synchronous as well as metachronous. Let me deal with synchronous metastasis first. So if somebody is newly diagnosed and has a single site of metastatic disease, how do you treat? It depends on the organ, for example, as I said, if it is a single area in the brain that can be resected, I would say resecting it would be the right thing to do, would be the first thing we would like to do. And then the subsequent treatment depends on whether the disease itself in the chest or the lungs is resectable. And if there is no mediastinal nodal involvement, obviously we would favor surgical resection. And there are no real level 1 evidence to say we should give induction chemotherapy or induction any systemic therapy before operating those patients. But the critical thing is, I would not consider operating on these patients with, there is evidence of mediastinal nodal involvement. So there's no mediastinal nodal involvement, otherwise candidate for surgery. Surgical resection for the primary disease is not unreasonable. And then depending on the size and what we find at the time of operation, perhaps adjuvant therapy may or may not be applicable to those patients. On the other hand, if they have mediastinal nodal involvement and otherwise they're fit, strong, and no other sites of disease, we have tended to give chemoradiation and perhaps now followed by durvalumab. These patients would not have qualified for the PACIFIC studies, and these patients have not been subject to any randomized clinical trials. But in practice, it is a problem. It is a good problem to have if one were to have a metastatic disease, and I would treat it along those lines, depending on what the rest of the disease would qualify for once you remove the oligometastatic site from the equation. What about if it's a liver or bone? That gets tricky. We don't like to operate, we don't do resection of the liver metastasis or bony disease. And I would say we should resort to radiation therapy. And we do have an ongoing NRG study where patients with oligometastatic disease get chemotherapy or chemoimmunotherapy. And after that, if they have no evidence of disease progression, they are candidates for, they'll be considered for stereotactic radiation therapy. I think that's kind of studies what we would really like to enroll patients for, and I would strongly encourage you to consider enrolling in the NRG or the RTOG, oligometastatic disease site with stereotactic radiation treatment. And of course, in that study, the systemic therapy precedes local therapy, and I think that's how I would approach in a synchronous metastatic disease. And adrenal metastasis is also another interesting problem. Of course, these patients may be considered for the NRG study I just mentioned, but we also should if they, for some reason they don't qualify for or they don't have access to the trial, a single site of adrenal metastasis could also be considered for surgical resection. And anecdotally, we have had patients who have survived many years after metastatic site resection. Again, it all depends on the performance status. Now we can do adrenalectomy through laparoscopic approach. It's not unreasonable to do. And in those instances, perhaps it may not be unreasonable to consider systemic therapy for a while. And then if they don't blossom into multiple sites of metastatic disease after 6 or 8 months, perhaps considering that if it still be a lone site of metastasis, it's something to consider. And I think these are context dependent, but the important message is if there is oligometastatic site of disease and the patients are otherwise fit and strong, we should consider them for potentially curable options. We end up curing only a fraction of them, and that information ought to be emphasized. and also we have to look at the benefit and the risk in this context. I think that's very important for the synchronous metastasis. That means they present with oligocytes of metastasis. Is there a biology behind this? Why some patients have oligometastatic disease and why some do better than the others? The conventional notion is once you have a site of metastatic disease, it's probably what we're seeing is the tip of the iceberg. These patients have multiple sites of metastasis. As you know, unless there are billions of cells we don't see, that is B as in boy. And it is conceivable that these patients will declare with the true metastatic disease in multiple sites. And that probably is true for a vast majority, but it is likely that in some patients, a specific clone thrives in some areas and they don't have high volume disease. And perhaps taking care of that subclone and that is thriving in a particular organ may give them a significant advantage. And we have come to appreciate that there are significant differences when you really drill down into deep, sophisticated genomic studies from the primary to metastatic disease. And if you look at the common mutations like EGFR mutation or ALK, they'll be there in the primary or metastatic site or p53. But there are subtle differences in the transcriptomic profile as well as in the epigenetic profile. And so these cells that grow in these organs are either they are specifically poised to grow well in those organs right from the onset of their at birth from the primary site, or they are very malleable. They adapt themselves very well once they go to a site of disease, and then they thrive. Regardless, they do well in a particular site. And the same cells may not grow very well in the liver or bone or other places. So removing that site in a given patient makes some sense increasingly as we understand this. We still have a long way to go to fully understand what really aids metastasis, what really makes them thrive at the sites, and how different they are from one site to another. I think we and others are all working on these areas, and hopefully we'll have much better understanding of these complex biologies. So the short answer is that synchronous metastasis, oligocyte metastasis, if it can be resected or radiated at the right time, we should consider doing that either before systemic therapy or after a period of systemic therapy. And then the definition of, in some instances, the patients may not even need systemic therapy. The example I gave you is a single site brain metastasis with probably a single lesion in the lung with no evidence of mediastinal nodal involvement, and they may just need 2 local therapies, and that may be not unreasonable as well. What about metachronous? And this happens a lot when somebody has, I shouldn't say a lot, this happens sometimes when patients have had curative therapy and they have a single site of metastasis. And in those instances, when resectable, we resect them, and we can radiate them, we radiate them. And in many instances, I don't even start systemic therapy once you've done a definitive therapy to see whether they declare themselves, and then begin systemic therapy only when we see evidence of disease progression, because we don't have any sites to follow if you really radiate or you take out a particular site of metastasis. So it is an area that we really are learning faster, and with better technology like PET scan and others, you're finding that more often. We also do more surveillance testing. And of course, one area that I didn't mention, and I'm sure radiation oncologists would love to expand on this, is the appropriate role of stereotactic radiation therapy in various organs, and most notably in the brain, that has changed our approach to the brain metastasis these days.